some very vague areas had been touched upon, some very dry topics has been touched upon. So usual common topics, which is a favorite for all these INISS papers, SS papers, those topics has been avoided, and even in those common areas like uro-oncology, very vague topics has been touched. So it is going to be a very difficult paper for all those students who have written. So don't be disheartened. This will be a low scoring paper for sure. When I was going back, and there were like for few questions we could not even get a reference from Campbell's textbook. There were direct references from the latest journals, and there were few references from the upcoming 2023 European Urology guidelines, that is EAU guidelines. Okay, so since now the focus is more towards this recent guidelines and journals, I am planning to take a complete revamp. The already existing videos, which covers the entire section of 12th edition of Campbell, will always be there. Along with that, I'm planning to take a session on covering on important topics of this. What is the updates in the latest 2023 EAU guidelines? So that I will start recording in a couple of months, and it will be available in DocTutorials app as well. Okay, this is to make yourself be prepared for those tough questions, because as I have been going through the papers for the last four sessions, that is in last 2 years, the difficulty level of urology paper is actually increasing, and certain things which I personally feel is actually not needed, because you are guys who are just finished dental surgery, and most of you would not have worked in a urology department per se. It is very difficult to expect you to know certain very core concepts of urology, and certain things which is not even mentioned in Campbell. That's quite disheartening on a personal note. But an exam is an exam, so we cannot comment on it. We have to be prepared to face it as well. So, for those who have been preparing who've been aiming for the next session as well, so don't worry. There will be a crisp session on where I will cover the whole of EAU guidelines of 2023, along with those topics which I think that has to be stressed upon. I will do it. Okay. So, for want of time, this whole paper is not complete. I have tried to recall as much questions as possible, and references. I have prepared the references for most of the questions. Few questions the references has to be made out. Anyways, I will just give you a clarity and answer with that. So I will share you the finalized PPT with you once it is done. Okay. So with this note, we will go to the first question. So as I already said, it's a sincere thanks to all our students and all urology aspirants. Without whose selfless contribution, this recall would not have been possible. Just a minute. Hello. No, wait for it. Wait for Bangalore the Bangalore bipolar. சரி, நம்மட்ட ரைட் ஆங்கிள் இருக்கா? 10 mm ரைட் ஆங்கிள் இருக்கா? ஓகே, இல்ல டாஸ்க் அந்த 10 mm ரைட் ஆங்கிள் கொண்டு வர சொல்லிடுங்க. சரியா? மார்னிங் 6:30 டோனர் நெஃப்ரெக்டமி, ரிசிபியன்ட் வந்து 8 o'clock. சரியா? இல்ல நீங்க 6 o'clock பேஷண்ட் டோனர் ரிசீவ் பண்ணிக்கோங்க. ரிசிபியன்ட் நான் சொல்றப்ப ரிசீவ் பண்ணிக்கலாம். சரியா? ஓகே. லேப் டோனர் ஃபாலோட் பை ரிசிபியன்ட். சரி. ஓகே. Sorry. So I would like to thank all our students. Okay, right. So with this note, I will go with the first question. So this is a repeat question of your previous NEET 2022 paper. The most common metabolic abnormality after urinary diversion using vaginal conduitors. So I would like to expect the students to just post your answers in the text box. A, hypochloremic hypokalemic metabolic acidosis, hyperchloremic hypokalemic metabolic acidosis, hypochloremic hyperkalemic metabolic acidosis, and hypochloremic and hypokalemic. Yeah, it is answer is C. Okay, so just forget about it is C. It is a so this is a very common, most frequently asked question. There are off late, even in the last NEET SS 2022 paper also there was a question here. So whenever there's a jejunum, you will have hyperkalemia. So everything has got some unique. When it is stomach, you will have this metabolic alkalosis. Whereas in ileum or colon, you will have both hypokalemic and hypochloremic. Just remember, I will just teach them why it is happening in the subsequent session. For want of time, we'll just discuss the answers along here. Okay. So for those who have already attended the urology video lectures, there's a detailed session on the intestinal segments and conduits, and we have discussed about the various metabolic abnormalities, why it is happening, and the mechanism behind it. But for this session, just want of time, you will just see to it. The answer here is C, and it is jejunum, where it is causes hyperkalemic, hypochloremic metabolic acidosis. One more question is, which among the following is the most suitable conduit? Is it a stomach conduit, is it jejunal conduit, or ileal conduit, or colonic conduit? Answer. This is not asked from fast for the exams. Just I need answers. Yeah. So as Dr. Akib said, ileal conduit is the best thing because the metabolic abnormalities are very least and malabsorption is very less. Okay. Right. So where do we use stomach as a conduit? There is one particular indication where we can use stomach as a conduit. In one particular age group. In pediatric age group, stomach can be used. Okay, right. So I will just tell you one thing. See, the metabolic abnormalities because normally the bladder is supposed to be non-absorptive. So whatever the urine secretes, that is going to stay inside the bladder, which is a non-absorptive urothelium, and it comes out. Whereas here in conduits, we take away the bladder and replace it with the bowel mucosa. But the natural property of bowel mucosa is to absorb those structures which is going to be present in it. So what happens is, whenever there is, for example, sodium, potassium, urea, everything is being present inside the bowel mucosa or the conduit, the natural tendency is to reabsorb them. So these patients, so whenever the creatinine, always the urine creatinine is more. So whenever there is urine secretes more creatinine, there is a tendency for this creatinine to get reabsorbed and recycled. So always this conduits, especially these continent conduits, are contraindicated in patients with renal failure. This is one add-on point. Okay. Right. So next question is, a HIV positive end-stage renal disease patient is being evaluated for renal transplant. What is the CD4 count cutoff above which the patient is deemed to be fit to be considered a candidate for renal transplant? Yes, Dr. Praveen, everybody said it is option B, that is more than 400. So this question, there is no direct reference from Campbell, but there is direct reference from Sebastian. I think for those students who attended the general surgery part of NEET SS pattern, I have discussed it and it is also given in your notes. Okay, there is one act called HOPE Act. That is, this act because for those patients living with HIV, because of want of donors, they can be both they fit for the recipient if the CD4 count is more than 400 and the viral load is non-detectable. Okay, right. So the answer here is more than 400. So this is a reference here. To select patients with appropriate cell counts of CD4 more than 400 and undetectable viral loads are good transplant for. See what I've said, and then the answer here is 400, which is direct pick from Sebastian. Okay, right. The next question is, below is a CECT of a prospective donor. What is the anomaly you find in the CT? I don't know whether it is an exact replica. I just followed your options and I have just put a picture of my own. I think you would have got an image like this. No, image was very different. So what were the options like? Are the options right? Retrocavalier ureter, retroaortic left renal vein, circumatic left renal vein, accessory left renal artery. So the image may be difficult, the image may be different, very difficult to replicate the image, but they are. But anyways, just for the 6 images of CT coronal. So option. Okay, anyways, I'll just tell you what it is and how to look for it. So one is retrocavalier ureter. Retrocavalier ureter, as you always know, it is seen on the right side, where the ureter curves across the IVC because of it is also called pre-ureteric IVC. So it goes behind the IVC and comes back. So usually this patient will have a right-sided hydronephrosis and it is commonly seen on the right side. Okay. So next thing is listen. Okay. Mata instruments all ready. Okay, fine. Vascular set kondu varu sollirunga. Avaru Ravindran avaru micro sets kondu varu. Okay. So this is about retrocavalier ureter. Next is just look at this image. Okay, what is retro-aortic left renal vein? So usually the IVC is anterior. So remember, this is the aorta. This is the left side of the patient. This is the right side of the patient. And here you have your IVC. Usually the left renal vein is anterior to your aorta. That is a normal anomaly. Whereas here what happens is, as you see in this image, it goes behind the aorta and it supplies the left renal vein. That is, here it is behind the aorta. It is called retro-aortic left renal vein. There is one more entity called circumaortic. Here what happens is, from the IVC, the renal vein divides into two tributaries. One goes anterior to the aorta, one goes posterior to the aorta. This is called circumaortic. That is, it is around the circumference of the aorta. It is called circumaortic left renal vein. And accessory left renal artery, it arises from the aorta itself. Here it is from the renal vein. Are you okay with this? So if you know these, what are these entities, you can look for it. Unless you don't know what to look for, then you cannot see what you expect from the image. This is very common, especially if you plan for a donor nephrectomy, especially in the left side. So when you see this, go through the CT images, you have to be very careful. Retrocavalier ureter I already discussed. It is on the right side where you have right side hydronephrosis. Here there is the anomalies with the development of IVC because of the persistent posterior subcardinal veins. Okay, so the IVC, the right ureter goes behind the IVC and comes anterior to it. So that segment of IVC which is behind the right ureter behind the IVC is usually atretic and this results in hydronephrosis. The treatment is ureterostomy or ureteropilostomy. So this is your reference. It's from Campbell. Okay, in retro-aortic renal vein, the single left vein goes posterior to the aorta and drains. There is one more question here. One more. The most common anomaly of left renal vein is circumaortic renal vein. This can be a subsequent question in a subsequent exam. Okay, right. The next question is: a 40-year-old male underwent ESWL, following which he presents with right loin pain. What is the next line of management? So I need. See, the options are incomplete. I need more input from students. Okay, so this is probably they're talking about a condition called Stein's trace. So this is the ureter. Probably there was a stone here for which the patient underwent ESWL. After stone fragment, there is some fragments which gets obstructed in the ureter and causing ureteric colic. So this condition is called Stein's trace. So can somebody tell what exactly is the question like? With moderate, obviously it is because of moderate hydronephrosis. Okay, they had given an X-ray finding. So X-ray finding you will show you will have a radio-opaque linear shadows in the ureter. Oh, yeah. So the counts were 15,000. Okay, that means the patient has got infection. So okay, so the question is like the patient has got fever and presents with emergency. Okay, and the counts were very high. So now you tell me. Now I get a clear answer. This patient has got a post-ESWL with ureteric colic, presenting with pyelonephritis with fever. So what is the treatment of choice now? Whether you go for a URSL, you go for a PCN, and is there any option of DJ stenting? One option was emergency ureteroscopy. Okay. Other options? Emergency ureteroscopy. Right. Okay. So other one is cysto RGP plus DJ stent. Next thing, DJ stent and PCN. Is there option like DJ stent along with PCN or only DJ? Both are different options. Two different. Okay, DJ stent and PCN. So now you can tell me. Okay, now you can tell me what is the best option here. Remember, this is a patient following post ESWL. Patient who got pyelonephritis. Does the patient presented with shock? Was there any condition like that? No shock. See, now this patient has got it's a stable patient. Very good. Now the patient has got post-ES stable complication forms strain stress ureteric colic with obstructive pyelonephritis. Now, in case of obstructive, there is no role for definitive URSL. You should not break the stone because this will already patient with sepsis. It will worsen the sepsis. Now, the idea is to relieve the obstruction. The obstruction can be relieved either in the form of a DJ stent, which can be internal, or you can put a nephrostomy and you can drain and you can take care of it. Now, the option between PCN, that is percutaneous nephrostomy, or DJ stent depends upon certain clinical parameters. If the patient is fit enough for an anesthesia, then we can take the patient under anesthesia for a DJ stent. If that is not possible, if the patient is very sick, very toxic, not fit enough for any procedure, you can just put a PCN provided the bleeding parameters are normal. So the idea is to drain the obstruction and relieve the fever. So the options can be both PCN and DJ stent. That depends upon the clinical parameters. If given by the fever, patient presents with emergency with raised counts, so the better option would be PCN in the setting because it can be done as a bedside procedure. Are you clear with this, guys? Got any doubts? Or are we missing something in this question? Okay. Then I'll move on to the next question. A patient with penile urethral stricture underwent the following procedure. What could be the most probable procedure he underwent? There is no role for conservative for the previous question if the patient is already toxic and running fever. Okay, if the patient has got ureteric colic, otherwise stable, you can give an attempt with alpha blockers and conservative. But with this scenario of patient having so with this scenario of patient having fever and toxic symptoms, there is no role for conservative therapy here. So this again, see, these image-based questions are even more difficult to recollect. So with the options, I'll just try to give one picture. Okay, a patient with a penile urethral stricture underwent the following procedure. What could be the most probable procedure he underwent? Can anybody tell? Or do you remember having this kind of options? Barbagless urethroplasty, Kulkarni's urethroplasty, Orandi flap, and anastomotic urethroplasty. Okay, Kapil. So this is a case of augmented anastomotic urethroplasty. So now I will just touch upon so many students have asked for different approaches of urethroplasty. So what is urethroplasty? Remember, this is the bladder, this is the penile urethra, this is your bulbar urethra, and you have here. So any stricture, so any narrowing here, either in the bulbar urethra or etc. So that has to be, so this patient will typically present with narrow urethra in the retrograde ureterogram and MCUG. Okay, so this is the stricture urethra. Now you have to repair the stricture urethra. How you can do? So if you see the cut lumen, so this is a normal lumen of your urethra. Okay, what happens in stricture? This becomes a stricture and narrowing. It becomes a small narrow lumen. So what we do here is we are going to do augmentation. That means so what is augmentation cystoplasty? You are increasing the capacity of bladder by augmenting a ileal patch or other patch. So here it is called augmentation urethroplasty. When you increase the circumference of your urethra by adding another structure, it is called augmentation urethroplasty or substitution urethroplasty. Okay, right. This can be done in there are different terms. Either you can put a free graft or you can put a flap. So what is the difference between graft and flap? So what is the difference between a graft and flap? It's a very basic question. Am I audible? Yeah, flap brings its own blood supply, whereas graft takes blood supply from the where a graft takes blood supply from the donor bed, from the recipient bed itself. Okay. Now here what happens will be stricture urethra. So what happens in stricture urethra? You cut the urethra like this. Okay. This is the urethra. You cut the urethra like this. and you augment, you put some other structure over it and anastomose to the sides. So this can be a graft or this can be a flap. This is called substitution urethroplasty. That means the urethra is being substituted by some other structures. Are you able to understand? This is the basic concept. This is the basic concept. Okay. So when it comes to urethroplasty, now the best graft is your oral graft. That is oral buccal mucosal graft. Why? Because it has got panlaminar blood flow and it is always in a wet medium which mimics the urethra more likely. So the uptake is much better. So whenever there's an option of which is better for urethroplasty, you can always go for a graft, buccal graft. Okay. So remember, usually the tendency is to go for flap because it brings its own pedicle. But when it comes to urethroplasty, the studies have shown that buccal graft is much better. Okay. So buccal graft is much better than a flap. Right. Again, see, this is the urethra. So I will just go back. So it can be in the form of, there are two things called approach. Other one is onlay or inlay. So approach means, for example, if you see, this is the penis. Remember the erect penis is in the normal anatomical position. Okay. So normally, so this is the urethra. So just take an example. This is the urethra. So this one, which you see on the direct aspect. So remember the penis is like this. This is direct. So this is the ventral aspect. If you approach, for example, if you cut open the urethra, so this is the anterior aspect. This is the posterior aspect. How we approach it? If you open the urethra through the anterior aspect, it is called ventral approach. Okay. If you approach the urethra from the dorsal aspect, that means you turn the urethra. That is, remember, the urethra is being mobilized all around. You cut on the dorsal aspect. Can you see this? This is called dorsal approach. Whereas if you cut open the urethra directly on the ventral surface, it is called ventral approach. There is one more approach called lateral approach, where you cut the urethra on the sides. Can you see here? You cut the urethra on the lateral aspect and you put a graft here. This is your graft. Understand? You understand this concept? Because this is very important. It is not completely taught in Campbell. It is either a ventral approach or a dorsal approach or lateral approach. So each one has got its own advantages and disadvantages. Okay. See, this approach is how we cut open the urethra. Okay. See, this is the urethra. I will repeat again for some students. This is the anterior part. This is the posterior part. Okay. So behind, see, here you have your corporal bodies and your triangular ligament, and here is your urethra. Understand? Okay. This is posterior. So now what happens? You have to, so this is a ventral approach. You cut the urethra here. You cut the urethra here and you go. See, remember, this urethra is covered by a muscle called, what is the muscle which covers the urethra? Come on, you tell me. Basic stuff. What is the muscle which covers the urethra? No, it is not cavernosus. It is bulbospongiosus. Okay. Bulbocavernosus covers your corporal bodies. Okay. The disadvantages, the bulbocavernosus is it is more on the anterior aspect. So you have to go through the muscle. You have to cut the muscle to reach the urethra. This is the urethra. So what happens? The bleeding is more common, and once you place the graft, you have to do a spongioplasty. That you have to repair the spongioplasty. That is one thing. That is the one advantage. Advantages, it is easy to approach because when you open, it is directly in front of you. You can open it. But the disadvantages, it will cause more bleeding because you have to go through the spongiosus muscle, and after placing a graft, you are going to close it. Okay, you have to close the sponge. We have to do a spongioplasty. The advantage of this dorsal approach is, here you have what is called, between the corporal bodies, you have this triangular ligament. So it is a very stable thing. Okay, and the spongiosus muscle is very little on the dorsal aspect. So you cut very little of your spongios on the dorsal aspect. So the bleeding is less. But the disadvantage is you have to completely circumferentially mobilize the urethra to approach the dorsal aspect. That is one disadvantage. But the advantage is less bleeding. And when you put a graft here, it is a more stable structure. It is not fixed. Remember, where you place a graft, graft will stay well when there is very little mobilization. That is when see, after putting a skin graft, you put a POP. Why you put a POP? Because you have to reduce the mobility at the place of your graft bed. Similarly, the graft sits very well here, and its uptake is much better on the dorsal aspect. This dorsal aspect is called Barbaglie's urethroplasty. Okay. Here what happens? You open the stricture, and between the defect, you take the buccal graft and you suture on either side. So that means what? You cut open here on the dorsal aspect, you put a buccal graft here. This is called dorsal onlay. This is called Barbaglie's urethroplasty, buccal urethroplasty. So Kulkarni modified this technique. So what he said was, instead of, see, the disadvantage is if you completely mobilize the urethra, there's a chance of bilateral nerve injury is more likely to happen. So to prevent the neurovascular bundle, because the neurovascular bundle lies on either side of the urethra. So to prevent the neurovascular bundle, he advised you rather go for, you mobilize on only one side of the lateral aspect. The other side is so that the neurovascular bundle is left intact. And you open the defect, and through the defect, you place a graft and you suture. This approach, lateral approach, is called Kulkarni's modification. Kulkarni's modification. So there is no fixed name for, so ventral urethroplasty. This is called ventral onlay. This is called lateral onlay. This is called dorsal onlay. Are you able to understand this concept? Okay, right. So next, there is one concept called non-transacting augmented urethroplasty. I will tell you what it is. See, remember, this is a dense stricture segment. It's a dense stricture segment. So, okay. So what we do here is, if it is a small stricture, you can go for, you can do the resection and you can go for an end-to-end anastomotic urethroplasty. Okay, this is end-to-end anastomotic urethroplasty. You cut open, and after that you just suture the segment. You spatulate it and you suture it. Called end-to-end anastomotic urethroplasty. But the disadvantage is, most of the times these strictures are inflammatory strictures. That means what? You cannot do this end-to-end urethroplasty. It can be possible only in some traumatic strictures, or if the stricture is very short. The stricture is very long. What happens? Because of tension, there will be a cardi happening. So this end-to-end urethroplasty is possible only in very limited areas. Okay. So here, what we do is, so here what we do is one condition called non-transact. This is called completely transact, non-transacting anastomotic urethroplasty. Here what we do is, we just transact the very narrow segment on only one side. Okay, you transact only this segment, and you do a anastomosis here. So it will be like this. Okay, so I have transacted only here at this point, and I did a suturing here. Whereas I didn't transact on the other side. It's called non-transacting. This is called non-transacting augmented anastomotic urethroplasty. So because, why non-transacting? Because we are not transacting the other side. Only one side we have transacted. So in this side there is a graft. So here you have to place a graft. What graft do you place? You place a buccal graft. So this is augmented with a buccal graft. It's a non-transacting augmented anastomotic urethroplasty. Do you get this point? Just have these ideas and then you go and read. It will help you out. Okay, you know why it got this name? It's because you transact on only one wall. Only one wall is transacted. So we are not completely transacting the other wall. So what is the disadvantage of complete transaction? There is a complete cut off of blood supply on either side. So that's why end-to-end anastomotic urethroplasty is done only in cases of traumatic strictures, not for inflammatory strictures. Because inflammatory strictures are long and it can progress both proximal and distal to the dense stricture segment. That is one point. I think this is sufficient. With this note, we'll just go and solve this question. Okay. A patient with a penile stricture underwent the following procedure. What could be the most probable diagnosis? So this is a stricture segment. So what happened was they were transected at one segment. So remember here, they have transected one segment and they have did this and they have put a graft on the opposite side. This is called augmented anastomotic urethroplasty. Augmented non-transecting anastomotic urethroplasty. So only if you know the concept, it will help you out. Okay, right. Next is, which among the following is the most sensitive investigation for diagnosing pheochromocytoma? So I need options. I need input from you. Were these options correct? MIBG scan, plasma catecholamines, urinary vandalic acid. Third one is Dotanet PET-CT. So now you tell me the option. If the options are right, just pour in your answers. We'll check. So MIBG, plasma catecholamines, urinary VMAs, and 68 gallium Dotanet PET-CT. So the option here, the answer here is PET-CT among this. So because it's a direct question, initially FDG PET was supposed to be more sensitive, but now that has been superseded by your gallium 68 Dotanet PET-CT. Okay. So if there is a question of plasma metanephrin, why plasma catecholamines is not an option here? Remember, they asked for the most sensitive investigation. So Dotatate. Okay. Dotanac, they call it by different names, but it is that one molecule which is supposed to be more sensitive than your FDG PET. So here, with this options, there is no doubt the answer is option D, gallium 68 Dotatate PET-CT scan. Okay. Why this 24-hour? See, is the answer urinary VMA or urinary metanephrin? I will tell you, if it is plasma, it has to be plasma metanephrin and it should not be catecholamines, because catecholamine production is episodic and it is not representative. Okay. So there is so much of confusion, but with this I will just tell you. So this is your reference. Okay, FDG PET has recently emerged gold standard modality for definitive staging of patient pheochromocytoma. More recently, 68 gallium Dotatate PET-CT has shown to exhibit superior signals, similar test characteristics when compared with FDG PET, and thus replacing FDG PET for imaging patients with pheochromocytoma. Okay, there is one more table which compares the different sensitivity and specificity, where the sensitivity of VMA is only around 60%. Okay, I think I forgot to add it, but it's in the very next page of this reference page. Okay, the next thing is all of the following are true except Pesopanib is a FDA approved adjuvant treatment for RCC. Pesopanib is a standard of care for RCC. Nivolumab plus ipilimumab has got better overall survival than placebo. The fourth option I could not recollect. Is the options correct? Or if you want to add in some options, please. Pembrolizumab is FDA approved. Is it so? Checkmate trial. So that is one option. Other one is checkmate trial. How about this option? Pesopanib is standard of care. Was there an option like this? There are so many variants of checkmate trial. Okay. No, was there an option like this? Pesopanib is a standard of care. Yeah, see, all this is for advanced RCC. This question is based on advanced RCC only. So then you tell me the answer. What could be the probable answer here? No, option B was there. So you just tell me what's the answer like. If I could not recall the question, it's very difficult for me to answer. Of course, pembrolizumab is FDA approved. Okay. So that is based upon this, your checkmate trials and this PD ligand inhibitors, that is the upcoming standard of care in adjuvant setting of RCCs, advanced RCCs. So this option is there, okay? So I just made this question based on the options which I was able to recollect, okay? So here, remember, this question is actually taken from EAU 2023 guidelines. So as you go through here, this is from EAU 2023 guidelines. The standard of care is either nivolumab or capecitabine, pembrolizumab or axitinib or pembrolizumab. So pembrolizumab is the standard of care. So that option is right. If there is one option like that, you can always go for it. Okay. Remember, it's all has changed. Previously, 4 risk factors we give for, you give them for mTOR inhibitors. They are not working. Secondly, we go for your program death inhibitors of pembrolizumab or nivolumab. Now it has all changed. Understand? So if that was the case, then pembrolizumab is FDA approved. That is the right answer. Any doubt here? So based on the thing which I had collected, like pasopinab is not the standard of care. That was the option which I thought that was the wrong option. But with your options, now tell me which is the wrong option here, guys. Now tell me which is the wrong option here. Are you there, please? So unable to recall. This was not the question. Okay, I understand. So one option is pembrolizumab is FDA approved. That is the true option. That is for sure. Option C looks like a true option. Both nivolumab and ipilimumab has got better overall survival than placebo. Option B is false, but you say option. Yeah, so even I know that I could not get the appropriate options. Option A is also okay. It's then approved for adjuvant treatment for RCC. Okay. So after the session, you just text me in the WhatsApp group. We'll just see what's happening. Okay. So that is right. That's a true option. All of the following are true with regards to carcinoma of bladder, except GATA3 is positive for luminal MIBC. Basal variant has better response with chemotherapy. Luminal variant has got better disease-free survival and overall survival. Option D, I could not recollect. So again, this is this question is taken from Campbell, no doubt about it. But there is only one paragraph on it and one flowchart on it. It is very difficult for you to understand because I have not explained it properly. But this question is based on the newer genomic classification of carcinoma bladder based upon the mutations which they are supposed to happen. So based on it, they divided the bladder cancer into broadly into two variants. One is basal variant, another one is your luminal variant. Okay. So each has got its own specific set of mutations and each has its own set of clinical presentation and progression. So now adding, so were the options correct? Or am I missing something, please? Okay, thank you, Dr. Prasun. So the option, so then tell me what would be the wrong statement here? Yeah, basal variant has better response with chemotherapy. Yeah, because that is a wrong option because luminal variant is supposed to have got better response to chemotherapy. So this is the paragraph which says the luminal group is characterized by high levels of FGFR, GATA3 and KRT and PAP3 mutations. Okay, and was biologically less aggressive. Okay, luminal group is less aggressive compared to basal type. That is one point you can get. Okay, so this is one group and this is one group where they have their own mutations. Okay, this is supposed to be more aggressive group. The next is all of the following are high risk factors for upper tract urothelial carcinomas except presence of hydronephrosis, lesion more than 2 centimeters, high grade and biopsy, high stage on CT scans. Are the options correct? Okay. Okay. So you tell me what, okay, most of them have answered that. Okay, probably it is 1.5 centimeter. Doesn't make big difference. The presence of hydronephrosis means it's already it is a T2 disease. Obviously, it is a high risk factor because the chance of extravesical spread is more common. And usually, high grade biopsy is more likely to have carcinoma in situ or more likely to have a progression of disease. High stage on CT, that is presence of nodal mets or presence of hydronephrosis or anything which is beyond the extravesical disease, more likely to have a high risk factor. So the option here is B is the wrong option. Remember, even Campbell says tumor size has not been established as a prognostic criteria, but tumors larger than 3 to 4 centimeters may be related to worse survival and has got high risk of bladder recurrence. You remember the different group stratification which I taught you. One is low risk, intermediate risk, and high risk. In the low risk group, it is solitary tumor, less than 3 centimeter tumor, and it is a primary tumor. So if it is more than 3 centimeters, it obviously the grade increases. Here the size cutoff is only 1.5, so you can go with that. That is a wrong statement. Understand? So next is a patient with urethral stricture underwent the following procedure. What could be the most probable procedure he underwent? Barbagli's urethroplasty, Kulkarni's urethroplasty, Orandi flap, non-transecting augmented urethroplasty. So I think most of the students said there was a question like Orandi's flap. So this is a direct repeat from your last INI December session, 2021 session. So for those who had followed my previous sessions, I have already discussed this. Okay, this question was taken from this. So there is no name by called Orandi mentioned in Campbell, but this I already discussed. Okay, this is one specific book for urethral reconstructive surgery, which gives it. So Orandi is nothing but a skin island flap. See, already said there are various ways to reconstruct. So what we do is you take the penile skin here. Okay, you take the penile skin along with its flap, along with its blood supply, and so this is mainly for your penile strictures. This is mainly for your penile strictures, where you have narrowing at this level. So what you have here, you have your penis. You take a flap here, you mobilize it, you augment to the penile urethra, penile stricture. Okay, it's called Orandi's flap. It was skin island flap. It is not a graft. Understand? Right. Next is very simple question. Most common enzyme deficiency in congenital hyperplasia is? So 21 alpha hydroxylase deficiency. Okay, 21 alpha hydroxylase deficiency. So it's a very simple question. Direct for 95%, it is 21 alpha hydroxylase deficiency. Okay. So it is one of the most common cause of ambiguous genitalia in newborn. Okay. Next is intravesical hyperthermic therapy in carcinoma bladder. All of the following are true except BCG is less effective than HIVEC, giving heated mitomycin intravesically, better response than regular mitomycin. Please recall the options. I am sure the options may not be exactly right. What is HIVEC? What is HIVEC? Guys, you remember a question like this? Okay, so you're right on target, man. It is like hyperthermic intravesical chemotherapy. So usually what do we do? So what are the indications where you give for this intravesical therapy? Tell me. In what conditions you go for intravesical therapy? Bladder tumor, what type? Low risk, intermediate risk, high risk? Low risk. No, acute, it is not in low risk. It is only in intermediate risk and high risk. Low risk means solitary, less than 3 centimeter tumor, primary tumors. Okay, right. It is only for intermediate and high risk. So it can be option HIVEC superior to BCG in high risk patients. So is it a true or false statement? Okay, I will just tell you. See, usually we give intravesical chemotherapy in the form of mitomycin, or you give intravesical BCG. So BCG is the only thing which is proven to be effective to reduce your progression as well as your recurrence, whereas your mitomycin chemotherapy is proven to reduce only the recurrence and not the progression. But to improve the efficacy, what happens is, to act the mitomycin to get into the urothelial cells, what they have done is they agitate the, they cause local inflammation by heating the urothelium, bladder urothelium, by giving heated mitomycin is usually heated to 42 degrees, and there is a constant motion is being maintained so that the mitomycin gets into the urothelial cells, and it is supposed to be more efficacious and more potent. That is the basic behind intravesical chemotherapy. So compared to a regular mitomycin, which is given at the body temperature, it is given at a higher temperature, it is supposed to cause local urothelial inflammation and helps in increased penetration of your intravesical mitomycin, helping in increased efficacy. But remember, study still shows that BCG, intravesical BCG is always superior than any form of your intravesical chemotherapy, either in the form of intravesical mitomycin or gemcitabine. So this is a reference here. It's from 12th edition Campbell, page number 3104. Hyperthermic intravesical chemotherapy, where insulin mitomycin is heated to 42 degrees in bladder and the form of continuously recirculating irrigation. Okay. So as you see here, although these results shows exciting data, randomized trials are needed before this approach can be incorporated into the current treatment paradigm. So still the current treatment is best is you have to go for your intravesical BCG whenever it is possible. A patient with suspected Conn syndrome, he is planned for bilateral renal adrenal vein sampling. What is the ideal route to sample left adrenal vein? It's a simple question. Are the options right? Are the options right? Okay. So now you tell me, what is the route? This is your femoral vein. Femoral vein continues your external iliac vein. It joins with internal iliac to become a common iliac vein, and both the common iliac veins join to form your IVC. At the level of L2, the IVC, the renal veins join them. The renal veins join them. On the right side, it's a single, it goes only to the kidney, whereas on the left, you remember this important thing, you have this suprarenal gland, and this is the IVC. So now if you want to sample the left adrenal vein, your approach is, this is your thigh. You cannulate the femoral vein. Through the femoral vein, you enter the common iliac vein, internal external iliac vein, common iliac vein, IVC, and you cannulate the left renal vein and you cannulate the left renal vein. This is the route. Are you able to understand? It's a simple question based on simple venous anatomy. Okay, right. So next is erdafitinib. It's a new question. So which among the following is true? It's a FGFR blocker used in urothelial cancer. It is FGFR, the fibroblast growth factor blocker in used in RCCs. It is an epidermal growth factor receptor blocker in It's a CTLA inhibitor used in bladder cancer. So what are the options here? Again, it's a very tough question. There is only one small point which says about it in Campbell. Do you remember this question, or am I missing something? Okay, Kapil. Okay, Amit. Good. So what is the answer here? Just give some try. So Kapil has given answer is A. Okay. So the option here, the answer here is, erdafitinib is a pan-FGFR, that is fibroblast growth factor receptor inhibitor, which is used for metastatic urothelial carcinoma. The reference is Campbell 12th edition, page number 2224. Okay, right. So the answer here is option A, used in metastatic urothelial cancer. It's a FGFR receptor blocker. The next question is Balkan nephropathy. All of the following are true except it is named so because of increased incidence in Balkan countries. It is familial, increased risk of bladder cancer. The carcinogen is aristocolic acid. Aristocolic acid. Are the options right? Or am I missing something? The options right? If that is the case, just give in your opinion on the answers. Okay, thanks, Arun. It is named so because, so the answer here is it does not increase the risk of bladder cancer. It increases the risk of only upper tract urothelial cancer. It's a direct pick from Campbell. Okay, it is from the chapter called upper tract urothelial cancers, where you see different etiology for thing. It is called aristocolic acid nephropathy, also called Chinese head nephropathy. It is most common in Balkan because of endemic thing. Okay, see, it tends to happen in families, but it is not inherited because the whole family is being exposed to the same kind of carcinogen. Okay, it is familial, but it is not inherited. Familial, but not inherited. So that is one important negative statement. It increases the risk of urothelial cancer, but it does not increase the risk of bladder cancer. That is one more negative point. Okay, right. So it tends to be endemic, it tends to be bilateral, and it occurs at an earlier stage, more than 10 years than the sporadic onset of UTC. Next is, as per the 6th WHO criteria of semen analysis, all of the following are true except. Again, this question is beyond Campbell. But those who have attended my classes where I took a session on male infertility, I have already touched upon it because the 6th WHO criteria of semen analysis is only the 5th WHO criteria is covered in your 12th edition of Campbell. But there was very small changes which I have already discussed in a session which I had taken some time back. So are the options correct? Or are we missing something? Please add on the 4th option also if any of you remember it. Okay, thank you, Kib. So volume 1.5 ml is the lower limit. Volume should be measured in the same container. Total number of ejaculators, 59 million per ejaculate is the lower limit. Remember, there is no absolute cutoff of beyond which the patient is infertile and above which the patient is fertile. It is only a percentile, that is between 5% and 95%. Okay, that is what we take. So the option here is, the false option is option A. So this was the, oh, sorry. So is it right? Is it 1.4 or 1.5? 1.4. So if it is 1.4, then C is the wrong option because it has to be 39 million per ejaculate. So remember, just remember, the 5th percentile is given in your Campbell. Whatever I have given in blue, that is, this blue is the changes. So from 1.5, the 6th edition has changed to 1.4 ml. And initially from 15 million, it has changed to 16 million per ml. And for sperm concentration, it is same, the 39 million per ejaculate. And motility is 42%. Progressive motility is 30%. Vitality is 54%. And normal forms is 4%. Just note down it, okay? Option, yeah, that's the 5th percentile. That is beyond which there is the lowest thing. If it is less than 5th percentile, it's very unlikely to father a child. So understand? So next thing is stones on pregnancy. All of the following are true except more prone for complications, more prone for stent incrustations, ESW is contraindicated, asymptomatic hydronephrosis is more common. So just recollect the options. Are you aware of this question or am I missing something? It's a little tricky question if the options are same. Option and stone passage is 50%. Okay. Symptomatic. Huh? So stone passage is 50%. So asymptomatic hydronephrosis is more common. Probably why? Why it is more common in pregnancies? The two questions related to pregnancy. Okay. So now with these options, can you tell me what could be the answer? Yeah, obviously because of mechanical compression, ureter pressing on the bladder. Remember, this hydronephrosis will be there only above the pelvic brim. The pelvic part of ureter will never be dilated in physiological hydronephrosis. If the pelvic ureter is dilated, that means it is pathological. So with these options, let me go here. These two things are very common. It is more prone for stent encrustation. So most of the time they put the patient on stents. You have to exchange the stent every 4 weeks. ESW is obviously contraindicated because of adverse effects on the growing fetus. If it is asymptomatic hydronephrosis more common, that is true option. If it is symptomatic hydronephrosis, that is a false option. More prone for complications looks like a true statement, but that is a false statement. That is a false statement. So remember, this is from Campbell, okay? The change in urinary chemistry that occurs during pregnancy in the form of hypercalcium and hyperuric acid is implicated for accelerated encrustation of ureteric stents. That is the reason why there is more chance of hypercalciuria and chance of more stone formation in pregnant women. Remember, symptomatic rate of 100 patients underwent URS reported overall complication rate of 8.3%, which is not significant. It's no significant difference in rates of urinary complications compared to non-pregnant population. Okay, so that means option A is a wrong statement. Is this option true? Was it present in the exams, guys? Option A. Yeah, obviously, see, there is one more statement. Conservative is more likely. You can always put these patients conservative with alpha blockers. That is also there. Okay. So if there is a chance of 50% stone passage, then that is a true statement. RIRS, obviously RIRS has got more complications. Symptomatic hydronephrosis is more common. Ureteric manipulation, it says what is 70 to 80%? Spontaneous passage. Okay, so there are some controversies. So after the session, just give your inputs on this question. So we will just reframe the question. Okay, we will reframe the question. So we'll go to the next question. Next question is, all of the following are true. BPH may present with storage LEDs. Underactive detrusor refers to atonia of bladder. Overactive detrusor has detrusor contractions in storage space in urodynamic studies. Pollakiuria refers to amino acid secretion in urine. Do you remember this question, or the options right, or anything has to be changed? Which of the following is true? Huh? So, okay. So it looks like BPH may present with storage LEDs. That's true or false? So leave over the question. We'll just go through each stem. BPH can present with storage LEDs itself. That's a true statement. Underactive detrusor refers to atonia of bladder. That means the detrusor is not contracting. So this is also a true statement. Overactive detrusor has got detrusor contractions in storage phase. This is also a true statement. Pollakiuria refers to amino acid secretion in urine. This is a false statement because it means there is increased urinary frequency. It has got nothing to do with amino acid secretion. So this is the false statement. BH for clinically something. I think probably they would have given a definition for underactive detrusor and overactive detrusor, probably. Okay. See, it's very difficult to take the same options. You have to understand the difficulty, you know, how difficult it is for me to recollect all these options from various students. So I have to add in some imagination to the options. I have to reframe the question. I know it's difficult, but let's see. At least it gives some replica of what the exact question is like. Okay. right? The next thing is, so patient is diagnosed with renal hiatus cyst. What is the next line of management? Transurethral installation of povidone iodine, transcystic installation of povidone iodine, cystectomy, start on albendazole and do nephrectomy. So are the options correct? And tell me the answers. It is simple. It's a case of renal hiatus. Unlike your liver cyst, there is no role for this pair, that is puncture, aspiration, and installation of povidone iodine is not going to be helpful. Okay, albendazole and cystectomy. So if there is an option of albendazole plus cystectomy, that is the best option. You have to treat the patient, you have to treat the infection, and you have to go for cystectomy. There is no need for nephrectomy. Okay, sometimes if it's a very small cyst, if it is asymptomatic, you can just treat the patient and albendazole alone. Okay, there is no role for installation. Okay, right. So the answer here is option C. This is a reference. Okay, although use of percutaneous puncture, aspiration, and injection re-aspiration is a good therapeutic in liver cyst, it is not done for lung or renal cyst, for which the only options are surgical resection or antiparasitic chemotherapy. Obviously, it's a long-term chemotherapy. You have to give at least for about 1 to 6 months albendazole. Right. Next is a 36-year-old female presents with recurrent UTI. On urethral massage, she has urethral discharge. MRI shows a type of following picture. What is the most probable diagnosis? Urethral diverticulitis, Kenny gland abscess, chronic cervicitis. Do you remember these questions? I think the options may be wrong. The picture may not be completely representative of what it was given in exams. Just add in your inputs. Let's discuss this question. Recurrent UTI was an option. Neurogenic bladder was an option. Okay, neurogenic bladder. 6 months ago, fever, recurrent UTI. Okay. Okay, recurrent UTI already given. Okay, right. So what is the probable diagnosis? Can anybody tell? On pressing urethra and not massage. Okay, okay, it is similar to pressing urethra. Okay, it doesn't make big difference. So what could be the probable answer here? Big bladder with contrast seen on MRI. It is not contrast. In MRI, the urine itself will act like a contrast. If it's full bladder, it looks like a contrast. So, given by this definition, it is most likely to be a urethral diverticulum. So, what is urethral diverticulum? There is an outpouching in the female urethra. So, what happens if you press? See, remember, this is your anterior vaginal. If you press the urethra through the vagina, you try to decompress by giving pressure, you decompress this urethral diverticulum will empty and it will cause urethral discharge. This because what happens urethral diverticulum, the urine gets stasis here, it gets infected, and because it is atonic, it cannot contract, it becomes a constant source of infection. If it is getting infection, it can go present with abscess or diverticulitis. So most likely the option is urethral diverticulitis. So when you see this is a urethra. Okay, this is your labia, female part. You have discharge through the urethra, that is an urethral diverticulitis. Whereas if you have a skinny gland infection, you will have a para-urethral discharge. It is not through the urethra, but it has a para-urethral discharge. That means it is a skinny gland infection. That is how you have to differentiate. Are you okay with this? Shall we proceed to the next question then? Okay. Next is a false statement about carcinoma bladder. So for subsequent questions, I may not have put the references because I didn't have adequate time, because I want of coming early today because I got stuck up in an emergency. I came very late. Okay. Anyways, we'll just discuss the questions also. False about carcinoma bladder. I don't think the question is complete. I need your inputs. End block resection, low risk, lamina propria. Question was about 2 centimeter papillary tumor. Okay, 2 centimeter papillary tumor. Okay, makes some sense. So what were the options, please? Any other input from the thing like N block low risk of recurrence. Okay, N block low risk of recurrence. Okay, that's a true option. Okay. Lamina propria involvement means high risk. Is it true or false? Smoking is a high risk of recurrence. Okay, recurrence. One small request. See, I've been making some changes. If any of you is kind enough to just send me the changes or the inputs which you had, I will give you the complete reformed questions and share with you in a couple of days. Okay, because again it's very difficult for me to remind again. So we'll be very thankful to you if whatever changes which we had discussed in the class, if some of you is kind enough to just add those and send me that, I will do a complete revamp this question, and so that it will look even more better, mimic the more realistic paper like. Okay, so it is about a 2 centimeter papillary tumor, N block resection, has a low risk of recurrence. That is a true statement. Lamina propria involvement has got high risk. Is it true or false? When you say it is high risk, it is false, because only if it is muscularis propria is involved, then that's a chance of high risk. Lamina propria still comes under low risk only. What is G2? G2 low risk. Is there anything like that? Grade 1, grade 2, grade 3? Is there an option like this? Can you recollect it? Okay. So usually now it is based on Paris grading. It is only grade 1 or grade 3. Initially it was G1, G2, 3, G3. Now they are divided into low grade and high grade only. So G3 refers to high grade. Okay. G2 means low risk, but still the G2 has actually been taken away even in the 12th edition of Campbell, but I don't know how this question came up. Okay. Smoking always has a high risk of recurrence. So the option here is, this is a false statement. Lamina propria involvement is. So what is N block resection? Can anybody tell what is N block resection? This is here. So what happens, especially in a small papillary tumor, by using laser, you can go at the pedicle and you can remove it en bloc. So olden days, the concept was you use a TU or PT, you resect the tumor from the top to bottom, then finally you dig deep and take a deep specimen. Whereas in a small tumor, you can go around the pedicle and remove it in en bloc. So that is the advantage of en bloc resection. The advantage of en bloc resection is, because you don't touch the tumor, the bleeding is less, you know the exact depth, and you can go and take the proper muscle specimen also. So that means, so if a proper en bloc resection, the low risk of recurrence. Why recurrence happens? If you don't take the good depth, the recurrence is likely to happen. If in a properly taken en bloc resection, the risk is supposed to be lower. The next is GFR. All of the following are true except GFR is lower in prenatal and increases child growth. Normal GFR is 5-fold higher than patients on end-stage renal disease. GFR is more accurately measured with creatinine clearance than inulin. Any options D? Somebody add in the option D. And are the options correct? Or anything is being missed? Okay, so obviously GFR is low and because nephrons has to mature and it increases as the child matures. Okay, so normal GFR is 5-fold higher than ESRD. You know the different stages of ESRD. There was a question sometime back on the tabular column, so go by that. Obviously the GFR is 5-fold higher than patient with ESRDs. Okay, and GFR is more accurately measured creatinine clearance than inulin. Is it true or false? Because creatinine clearance is supposed to falsely elevate the GFR and show. So creatinine clearance is not a true representation of your glomerular filtration rate. So the option is again directly from Campbell. Tubular secretion of creatine may account for more than a third of creatine measured in urine and thus may artificially inflate the creatine clearance related to true GFR. Okay, it's a very old question, but still it's been taken. This is a little tricky question. After radical prostatectomy, prostate cancer progression follow-up is done with prostate health index, confirmed DX, decipher test, and MIPS. Decipher test. What are these tests? They are different genomic tests which helps in predicting the cancer progression post radical prostatectomy, or which helps in predicting the incidence of significant prostate cancer following a prostate biopsy, or these are certain tests which help us to decide whether to go for biopsy or not. There are so many tests, but this decipher test is one which is helpful, and it's a 22 marker genomic classifier developed for use in post-prostatectomy setting. This is one test which is used for in post-prostatic setting. Okay. In men with high-risk disease and those with biochemical recurrence, genomic classifier is demonstrated to be independent of with development of metastatic disease. So this helps to say for how many years this patient is going to survive without clinical progression, etc. Okay, right. So based upon it, the patient can be classified into low, intermediate, high-risk categories with 10-year cumulative incidence of metastasis. Understand? So this is from EA guidelines. This I have collected from an urology masterclass session from CMC Vellore. I'll just share it with you. So there are so many things like Oncotype DX, P10, Prolaris, Decipher, etc. So just you may get a question. Okay, it's been given in Campbell. Certain test has been given, sometimes has not been given. But since it has already been asked, I think it is right thing for you to learn all this stuff as well. Okay, right. Next is a question on, again, a common topic. Xanthogranulomatous pyelonephritis, all of the following are true except E. coli is the most common causative agent, often unilateral, more common in diabetes. CT is diagnostic. Come on, tell me. This I have already told in classes. I already told in urological infections, the most common organism is always E. coli. There is one exception where it is Xanthogranulomatous pyelonephritis. It is by gas forming organism, and Proteus is the most common organism. How does this Xanthogranulomatous present to you? It can mimic like any disease. It can mimic like an RCC. It can mimic like an renal abscess. It can mimic like a non-functioning tumor, etc. How does a CT is diagnostic? What is a typical picture you get in CT? Again, an MCQ. Yeah, it is a beer pass sign. So what happens is dilated calyces with a central scarred renal pelvis, which gives a beer pass sign. Okay, beer pass sign. Good. So what is the treatment option? What is the treatment option? You have to go for nephrectomy. But remember, it is very difficult. Though the name says it's a simple nephrectomy, it is going to be one of the difficult nephrectomies you are going to perform. Okay. Next is Hounsfield. I think, sorry for the spelling mistake. Hounsfield units are a measure of tissue texture in CT. All of the following are true except Yad 0 Hounsfield units, fat less than 0 Hounsfield units, bone more than 1000. And there is one option D. I think that's the wrong option probably. So what's the right answer? So you had one question on adrenal adenoma also. What is the fourth option, please? So less than 10 units suggest you of adenoma. Is that true or false? So that's a true statement. So fat means it has to be negative. What is the Hounsfield for air? Now I got confused. For fat, Okay, it is minus 1000. Yeah. So the answer is D. Right. So for angio, so what is the Hounsfield units? When you say it is for angiomyolipoma, again MCQs. Only one benign tumor which can be confirmed, which can be diagnosed. Yeah, it is minus 20 Hounsfield units. What is the Hounsfield units for RCC? There is any enhancement more than dash Hounsfield units is confirmatory of, it is plus 15. Plus 15 for RCCs, minus 20 for AML. Okay. Right. So RCC, all of the following are true except chromophobe RCC arises from alpha intercalated cells of collecting duct. Papillary RCC is more common in ARCDs. Medullary RCC has got poor prognosis. Is the question right? Or any tubular and mucinous associated with worse prognosis? Okay, now you tell me, what is the wrong statement here? So where does chromophobe RCC arise from? Chromophobe RCC, they arise from distal collecting tubules, right? Not from the collecting duct. Yeah, so that is a wrong statement. Papillary RCC more commonly arise from acute renal cystic disease. Obviously, we know medullary carcinoma RCC has got poor prognosis. So the answer here is A. It arises from distal collecting tubules. So next is, this is a very tough question. Belzutifan, all of the following are true except it is a hypoxia-inducible factor 2A blocker, useful in renal VHL and external VHL, only useful in VHL. It is given orally. Are you aware of this question? Okay. How about the options? Options are correct, or are we missing something here? Thanks, Praveen. Okay. So just a guess. I think probably by this time you could have Googled it. So there is no reference from Campbell. There is no reference from Campbell. This is taken from AU 2023 guidelines. Usually all these guidelines will be incorporated in a subsequent edition of Campbell, but this is too much for this level because we don't expect you to read the journals and update yourself. You have to read the textbook. Textbook is one thing which is going to be standard for the exams. But still, since there was a question, I had to go back and do. It is from AU. It is the answer. It is a hypoxia inducible factor 2 alpha blocker. It is useful for VHL. VHL is von Hippel-Lindau associated RCCs. Okay, and it is a drug which can be given orally. Okay, and it is not proven to be effective for extrarenal manifestations of VHL. So the answer here is B. Okay. I will share the reference. I have taken the references, but for want of time, I could not add it here. I will share it in a couple of days with the refined questions and the options. Okay. Next question is on squamous cell carcinoma of penis. All of the following are true except nodal involvement associated with poor prognosis, but surgical resection improves. As a rule, distal metastasis is always preceded by an inguinal nodal mets. Nodes in femoral canal are removed in superficial inguinal lymph node dissection. Any option D? Any option D, guys? Suddenly the group is silent. In previous question, chromophobe arises from crossover at symphyseal region, lymphatic clinical due to crossing of. Okay, so obviously that's a crossover of lymph node surfaces. What is the option here? So lymph node, lymphatic crossover is present. So remember, it is very simple. Even if you don't know other things, what is the node in the femoral canal? It is a cloacat node. It is an example of your deep inguinal node. So that is not a part of your superficial inguinal lymph node dissection. Remember the class which I had taken, the boundaries of So what is superficial inguinal lymph node dissection? So what is the deep? What is the posterior limit of superficial inguinal lymph node dissection? You don't go beyond this structure. What is the structure? No, deep. You don't go beyond the fascia lata. Okay, if you cut open the fascia lata and go beneath, then you take the deep nodes as well. Okay, then get the deep nodes as well. Just a minute. Sure, ma. ஆமாம்மா மார்னிங் கொடுப்பாங்கம்மா. ஆமா ஆமாப்பா. ஆமா ஆமா இல்ல 4 o'clock கொடுக்கலாமா, ஒன்றும் பிரச்சனை இல்லை. 4 o'clock கொடுத்துக்கலாம். இல்ல முன்னாடி கொடுத்துருங்க, முன்னாடி 4 o'clock கொடுத்துருங்க. ஏன் 1 hour கேப் கொடுக்க சொல்லுங்க. டிரான்ஸ்பிளான்ட் கேடிஆர் ஸ்டாஃப் இருக்காங்கல்ல, அந்த ஸ்டாஃப் பேஷண்ட் பார்க்க சொல்லுங்க. ரெகுலர் ஸ்டாஃப் பார்க்க வேணாம்னு சொல்லிடுங்க. கார்த்திகா அந்த பொண்ணு இருக்காங்கல்ல, மாலை, அவங்க கிட்ட பார்க்க. ஏன்னா அவங்களுக்கு தெரியும் ப்ரிகாஷன்ஸ் என்ன வேணும்னு கேட்கணும். டவுட் ஆனா மேம் கேட்க சொல்லுங்க. யூஷுவல் சாலிமெண்டல் போட்டுட்டு தான் அதுக்கப்புறம் தான் பெசிலிக்சிமேப் கொடுப்போம். சரி, ரியாக்ஷன்ஸ் வரணும், வைட்டல்ஸ் எல்லாம் பார்த்துட்டு சொல்லுங்க. சரி, ஓகே மேம், தேங்க்யூ. Okay, sorry. So, since I was talking, I lost. Where do you use this besiliximab? So, what's the use of besiliximab in urology? Okay, yeah, good. So tomorrow I got a transplant. So usually, if it's a related donor and the match is much better, you can go for a less potent immunosuppressant of besiliximab. Whereas if it is a non-related or HLA match is poor, you can go for a, what is the other form of induction you know of? So it is little outward from the exam anyway, since we touched. Yeah, ATG. It is anti-thymocyte globulin. So which is a more potent immunosuppressant? Is it ATG or besiliximab? So ATG is a more potent immunosuppressant. It causes severe lymphocyte depletion. Okay, so the advantage is if you give ATG, the chance of acute rejection is very less, but on the other hand, the very high chance of getting opportunistic infections. Whereas besiliximab is less immunosuppressant, but the chance of infections are slightly lesser in besiliximab. That's why when you suspect, when the match is better, HLA match is better, you can go for a less potent immunosuppressant in the form of besiliximab. What are the other drugs you commonly give apart from this? You give your, what is your triple therapy? You go for one steroids, mostly in the form of methylprednisolone initially, followed by oral prednisolone. Then you go for your tacrolimus and you go for mycophenolate mofetil. These are the commonly used immunosuppressants which you usually give. This tacrolimus and the MMF usually will start before 3 to 4 days prior to the transplant, and usually this induction is given on the day of surgery, day 0, and followed by 4th day post-operative. Okay. Right. Okay, right. Now we'll come to this question. So option D is the wrong option. Option D is the wrong option. It is cloacat node is a form of it belongs to a group of deep inguinal nodes. Okay, so the cutoff is your fascia lata, and you know the difference between a Catalano's modification of superficial lymph node dissection and other superficial lymph node dissections. Very often repeated common questions. Most favorite question: what is the boundaries? What is the medial lateral boundaries? What is the thing like? What are the different modifications you know of Catalano's modification? These are things you have to remember. So name the artery marked in the picture. So this, I forgot to add a picture. So usually it is like you have this corporeal bodies. If you remember right, there was one question like this. You have this bulb and you have an artery like this. There is one branch and one branch which goes through this bulbospongiosus muscle, which supplies the urethra, and there is one branch which goes to the cavernosal bodies. So the question mark was this. Is that right? They asked you to, yeah, okay. So what is the answer here? It is most likely it is a bulbourethral arteries, okay. So bulbourethral artery go through the bulbospongiosus. It is a main supply for your urethra, whereas this cavernosal artery goes to your cavernosal bodies, which is responsible for your penile erection. And there is one small branch which goes on the dorsal aspect and it supplies your dorsal, that is the dorsal penile artery. So all these arteries usually originate from one branch, that is a common penile artery. What is the common penile artery? What is the origin of common penile artery? What is the origin of common penile artery? Yeah, it is the terminal branch of your internal pudendal artery. Very good. So that is the internal pudendal artery continues as common penile artery. Very good. Very good. So next is corporoamylacia. All of the following are true except it increases the risk of harboring prostate carcinoma prostate seen as calcification. It's a surgical capsule between your transitional zone and peripheral zone. What is the fourth option? Are the options right? Are we missing something here? So the answer here is this is a false statement. Does not increase the risk of carcinoma prostate. It is nothing but these are the encrustations of your prostatic secretion. It is usually seen between the transition zone and peripheral zone, which is actually the capsule of your BPH adenoma. Okay, it helps. It forms a surgical capsule. Okay, yeah, it is seen as calcification in ultrasound. True. The next is there is an image of laser is being given, and I could not recollect the exact picture, but from students showed that there were three things, generators, and from there is one thing like this. It is most likely to be a thulium laser. Can you add on, guys? Please add on the points. What was the exact picture like, and what are any other points? High grade, high and low power was the option. High and low power. Low power, what laser? Is it a holmium laser, or what is it like? Diode laser. Okay, I'll just check that out. What is the option? One is high power holmium or thulium? Holmium, okay. Low power holmium. So if you have more generators, that means it's a high power machine. If it's a single generator, it's a low power machine. That's the basic stuff. Anyways, I'll just go through it and come back to you, okay? So that means, see, it has got one window, one laser generator, okay? If you use multiple things, then you produce as a high power. Then if that is the case, then probably it is a holmium, high power holmium laser. Anyways, I'll just check that out and take a call, okay? Next is a patient developed acute kidney injury following radical nephrectomy. For which the patient required hemodialysis. What is the grade of this complication as per Clavin-Dindo classification? 3A, 3B, 4A, 4B. Direct question. So nothing more. It is a 4A. That means it is a direct take from Campbell. So just go through this. 4A means there is a single organ dysfunction. Here the organ dysfunction is your renal, which for example, patient got acute kidney injury, which requires a hemodialysis. Okay, correct. So again, this is an often repeated topic for exams. You will have a different scenario, different post-op clinical scenarios, and they will ask questions different. So you have to be thorough with this. Okay, Clavin-Dindo classification. So there are few questions on this. I'm not going to discuss it. I will go back, find the reference and tell, but I just posted here for you to recall the options. Is there a question like this? When disease-specific mortality is calculated, the following bias is more likely to occur. Length time bias, selection bias, observation bias, and attrition bias. Okay, so you just help me with what could be the answer here. It is attrition. So attrition means the disease is more potent you will tend to lose the patients. So that is called attrition bias. That is one more question. Screening test is more likely to detect slow growing tumors than aggressive tumors. What is this bias? Length time selection bias, observation bias, and attrition bias. Again, it is a length time bias. So if it is an aggressive tumor, the patient survival is very less. So sometimes you may tend to miss it. That is called length time bias. Anyways, I'll just go back and send you with the better references. Okay. So which one of the following is not useful for stone fragmentation? Simple question. Thunderbeat, lithoclast, cybervan, shock pulse. So remember, so most of you would have used Thunderbeat is a form of energy source for tissue coagulation, both ultrasonic and harmonic. Okay, right. So other lithoclast, cybervan are different energy sources which helps in stone breakage, pneumatic and ultrasonic stone breakage. Whereas Thunderbeat is a vessel sealer. It is for coagulation and tissue sealing. Okay, right. Next is, what is HA index? So again, so is the question correct? Just help me to fill with the other options as well. The question is correct. So this high impact, I think, it tells, yeah, H factor. So it tells about how significant a particular journal or particular paper is like. Okay. Right. So what is the question like? Okay, somebody please, after the thing, we'll share it on the group. We will discuss that. Okay. Next question is, allergy-like reactions, all of the following are true except it's IG-induced, idiosyncratic, dose-dependent, and low osmolar. The contrast causes less than 10% reaction. So what is the answer here? IG-induced, idiosyncratic, dose-dependent, low osmolarity. Answer which is true. Okay. So what's the answer here? Okay. So it is idiosyncratic. Okay. Right. So I'll just go back and check again. Okay. Next is, this is an UDS tracing. What is the most probable diagnosis? I think probably with what you have said. So it had something like this. It is a PDET, it is a PVIS, and this is an EMG. Storage phase, there is nothing like this. During voiding phase, there is an increased rise in detrusor. Similarly, the EMG was also more active during a voiding phase. This is what I inferred. Is it correct, or are we missing something? PDES and PVIS was increased and EMG was active. Okay, so that settles the things. What it is like? It is a dyssynergia. So when you expect the bladder to contract, you expect the sphincters to relax. Okay, but what happens? There is a dyssynergetically both the sphincters also contracting and bladder. So it is called detrusor external sphincter dyssynergia, more commonly seen in spinal cord injury. I have taken a number of times. Okay, so in BPH and stricture, there will be a high pressure, low flow. There will not be any detrusor, any EMG activity. The sphincters will be completely synchronous. Okay, what will happen in supraspinal injury? That means the lesion is between the brainstem and the cerebral cortex. There you have only small detrusor over activities, but the coordination will be perfectly alright. Here the lesion is above the pond. Yeah, very good. It's only overactive, that is above the pontine maturation center. Good. Which among the following surgical robots function in a different way? Is this a question, right? So the question is different arms. Huh? Yes. Something about the arms of the robot. Okay. See, it's very simple. Yeah, arms work in a different way. So I will tell you. So Most of you would have seen Da Vinci in textbooks or in few institutes. If you happen to see, it is like there is one machine and it has 2-3 arms. Okay, all docked in one machine. This is a prototype you see in Da Vinci. So these are Myntra is something Indian-based company which is coming out with a mimicking a Da Vinci-like robot. Da Vinci, you know, that is the gold standard. Veseris is similar to Da Vinci. Whereas in Hugo, what you have is you have a robo with different, the arms are separate. You have to separately dock it. So when you put the patient like this, to separately dock it, and each robo has got a different arm. All three are not in the same console. So all these things can be operated, but it is like different hands operating on. Whereas in Da Vinci or other things, there is one robo with multiple arms which operate. Whereas in Hugo, there has got one different robo which operates. There is one different robo which has a different arm. Each machine will have one separate arm. That's why the answer here is Hugo. Okay, I will share the pictures. So next is neuroblastoma. All of the following are true except it's a benign tumor, presents with mass in the abdomen, arises from parasympathetic ganglia. Option D. So what is the answer here? It arises from sympathetic or parasympathetic? It arises from sympathetic ganglia, not arises from parasympathetic ganglia. Mostly differentiates to benign. Yeah. Okay. So option C is the wrong option here. Gas embolism, all of the following are true. So I think it is based on a general surgery part. Anyway, since you have put in, I have just added here. Can occur during lap cholecystectomy due to bleeding of venous channels, increase in EtCO2. Patient has to be put in left lateral decubitus position. What is the option D? Please recall this question. So what is the answer here? Initially decrease EtCO2. Okay, right. So why do you put the patient in left lateral decubitus? What is the idea of doing that? Fourth, CO2 solubility is more than helium. So my question is, why do you put the patient in left lateral decubitus? How do you prevent it from entering the pulmonary circulation? Okay, the idea is to prevent the gas. Okay. No. So the idea is to trap the embolized gas in the right atrium, and right atrium can be accessed through a central venous line. Okay, and you can aspirate the gas. So that is how you try to trap the gas in the right atrium and prevent them into entering into the pulmonary circulation. Okay, that is the question. Right. So next is renal and ureteric colic. All of the following are true except. So I'm not sure about the options. I need help from you. Okay, ureteric colic does not radiate to the back of the thigh. Is that an option? Both can occur together. Ureteric colic can radiate to labia, inner thigh, and ipsilateral shoulder. Both are synonymous. Renal colic is a misnomer. So ureteric colic means it is because of distension of the ureteric wall and hyperperistalsis, whereas renal colic is because of the distension of the renal parenchyma. I'm not sure about the radiation because usually does not radiate to thigh, etc. Okay, but both can occur together. Both are not synonymous. Okay, renal colic is a misnomer. It does not radiate to chest and thigh. Okay, I'll check with the reference. But what are the options? Is option A correct? Was it the same option that you got in the exams? Both are not synonymous. Okay, that was one option. Okay, Dr. Garima. Uretricolic radiation is given in Bailey. Okay. Okay, of course, uretricolic and radiate to labia, inner thigh. Okay, I'm not sure about the shoulder. I don't think that's the right option there. That depends upon the level of the stone. If the stone is at the upper ureter, likely to radiate. And back of thigh. I'll just check that out. Okay. Both can occur together. That's a true option. This is a true option if it is not synonymous. Renal colic is a misnomer. Again, that is a true option. Maybe that radiation. Okay. Okay, he was not there. Okay. So maybe that radiation may be the wrong option. Maybe here, if it is not ipsilateral shoulder, then again C is also a true option. I'll just check that out and I will reframe the question. Right. So GU TB, all of the following are true except the second most common form of extrapulmonary TB. Asymptomatic prevalence is 25%, only caused by mycobacterium tuberculosis and bovis. Is the options correct? Are we missing something here? Option B, infected by direct inoculations. It's not so common. Usually it is hematogenous is the most common. Okay. Option second most common, through lymph nodes. Okay. Prevalence of latent TB front, that is also true. Maybe infected by, okay. This looks like the wrong option because the only two common routes are there. One is either hematogenous spread where it directly comes to the kidneys, or where it is ascending, where it mainly affects the globus minor of epididymis and it spreads there. Okay, right. Next is narrowband imaging. All of the following are true except 415 and 540 nanometer are used. Absorbed by hemoglobin, helps in identifying bladder tumors, can be used in laparoscopy. Vascularized parenchyma can be visible. From psoas abscess can directly inoculate. Okay, but that is a very unlikely option, Dr. Kapil. So what could be the wrong option here? This is definitely a true option. This is also a true option. This I'll check that out. I'll check and tell. Okay. Okay, I'll check that out. So narrowband imaging, all of the following are true except absorbed by hemoglobin, helps in identifying bladder tumors. Obviously, that's true option. What is narrowband imaging? It is more like doing a histopathology that helps in the depth of the lesion. So absorbed by hemoglobin is, that is photodynamic therapy. Okay. Yeah, that is good. So next is, so the following is false of effective radiation dose more than 10 millisieverts is carcinogenic, calculates biological response, measured in sieverts, measures carcinogenic side effects. Options correct? Are the options correct, guys? You tell me the answer here. So tell me the answer, Dr. Akib. So it is the dose that has been taken up by the tissues. Okay. So it is measured in sievert. That's a true option. It calculates a biological response. So then just, so if the options are not right, you just jot on the true options. I will check that out and come out with the answer. Okay. but it's a direct pick from Campbell. So this was one question. A mode ultrasound, this may be carcinogenic. Okay, that can be true. A mode ultrasound of renal lesion shows the following graphical recording. What could be the lesion more likely to be? Again, this was very difficult to recall. Somebody has shared me some pictures like this. Is it like this? Am I correct? Had they given any graphical recordings in the question? Okay. So what was the exact image they had given? This one, this A, B, or C? So remember, this is just by using the principle of ultrasound. So ultrasound means it sends signals. So here is a target. Some goes through it, some go through the tissue and get reflected, which is also received by your transducer. It sends both same thing. Send signals, also it receives the signals. If it is a simple cyst, there are only two interfaces. One hits the anterior wall, one hits the posterior wall and come back. So that gives two spikes. If it is a complex cyst, that means cyst which some septae are there, that means some will strike this and come back and give a curve. Some will go through this and will have give a small curve. Some goes and hit back and come back, which gives one more curve. Okay, that is a complex cyst. If it is a completely solid tumor, homogeneous tumor, so that means the tissues goes and gives continuous spikes. That is the basic concept of ultrasound. Okay. Now, what type of curve they gave and what was the options were in the what were the options given? Can somebody recollect it? Yeah, I need somebody. Yeah, 4 images are given. Options were graph. Okay. Same image sent in group. Okay. It asked low gain cystic. Okay. So that is the two options, low gain, high gain, that is different. If it is low gain cystic, then this should be the right answer. If it is a simple cyst, there should be only 2 peaks, one for the anterior wall, one for the posterior wall. Okay. Right. But again, I personally feel this is little too much. Okay, this is for more like an exam for radiologist. Okay. But anyways, subsequent sessions we will focus on these dry areas as well. Okay. There was this one ultrasound based image question, which is more likely to be, is it an AV fistula? It's a bladder tumor. If it's an ureteric jet, or it's a bladder calculus. So what was the image? Is that anything specific about it? See, it looks like some flow is happening. So not all these colors are blood supply. It depends upon the Doppler sheet. If it is towards the probe, it gives blue color. Away from the probe, it gives red color. Okay. So it looks like some urine has happened. It's called ureteric jet, most likely to be. Have they given any clinical scenarios, guys, with this question? No, that's so most likely it can be a ureteric jet. So with this, I just conclude. I was able to collect around 50 questions. Again, I would like to really thank you, because I have not appeared for the exams. If not for you collective things, it is very difficult for us to recollect. Okay, again, this paper, of all the paper recalls I have done, this is really a tough paper, I should say. Yeah, there is one question on GOH. I forgot to add. GOH classification is used for your VVF, vesicovaginal fistulas. Okay, it's a direct question. Okay. Yeah, there is one question on waterfall plots and images. Okay, I will go through the images you have shared. Okay, I will just check that out. How come you are able to get the same images, guys, from Google? Okay, good. Even the examiners has used. There is one question on this high intensity focus ultrasound. Can somebody share the question? Recall the question, please. There is a question on HIFU. What are the options, please? So what was the question like? Okay, more than 50,000 hertz, temperature more than 100 degrees. Okay, that is option A, option B, option C, D. Option C and D. So can you recollect and just post this in the group? Okay, that is I have written temperature 100 degrees, required for coagulation, more than 50,000 hertz. Okay, anyways, we'll just focus on this HIFU topic. Okay, okay, I'll just check. It's all been discussed, man, but when you sit down and compile, again, it's very difficult, you know. So just tend to miss everything, get lost in certain questions. So, but for time, then I could have actually added, I could have been more precise on this. But again, I think we have covered most of the questions here. So as I already say, it's a very difficult paper because I have been doing this recall for past 2 years now. So once the aims has changed to INISS, the pattern has changed little differently, but still they try to touch on the important topics. But this paper is slightly off-centric, I should say, because there are certain questions which have been taken from EU guidelines, from certain journals. Usually there will be 1 or 2 odd questions, but this time the questions were little off-centric only, I should say. And even in Campbell, they took from some very dry areas as well. So it doesn't matter. So all of you will feel this paper to be very tough, and it will be a low scoring paper for sure. But don't worry, all those who are prepared, and especially I could see a lot of students who come out with very good answers. So that means you really done well. Okay. So this extra effort you had put in, no, just even after the exams to know how you good, that really tells the effort you have put in. So hats off to all those guys who attended. And there's one more question on urethroplasty. Yeah? So there are 2 questions on urethroplasty. One is based on Orandi's flap. One question is based on augmented urethroplasty. That I think. What is this autonomy beneficence? I'm not aware of this question. Please share the question, please. So placenta percreta, there's a chance of hematuria, if I remember right. Okay. So there is one question on placenta percreta, that is pregnancy. I'll just check that out. If possible, I'll come out with. See this. Maybe in a couple of days, I will refine the questions and I will share it with you. Don't worry. See, knowledge is to share and nothing to hold with us. Okay. So once the results are come, please update me with your ranks, whatever be done. Don't worry about it because it's a very competitive exam. Only the top 15-20 ranks are going to get, and it doesn't stop here. There is one more clinical scenario based Viva voice question is there, and every time I conduct a mock exam. Usually there will be a set of 4 to 5 questions for all the students. All this for urology that depends on different specialties. When it comes to urology, almost all the students who have been asked to attend the AIMS interview will have the same set of questions. One will be an image-based question, one will be a specimen-based question, one will be a clinical scenario-based question. Okay, and sometimes we may have one more question. So once the results have come, I will add on to it. I will have a small session on those guys who have been selected, and those who have not selected also. It will be open for all you as well. We will have a small clinical mock interview session as well. That will really help you to face the exams. That's what most of our students who have been in institutes now will really thank us after they got selected. Okay, so that I will conduct once the results are out. So meantime, just keep reading. This exam does not stop here. You have your NEET SS coming again. You have this INI SS in another four months coming out again. But really, those who are applied for INI SS is very good because you put that extra effort from the rest of the others. And remember, if you get into INI CTSS, definitely you're at least 2 years ahead of your competitors who get through NEET SS. I tell this often again and again for all my students. So don't worry about that. Okay. So be in touch. All the very best. So any other doubts, any other questions, I'll just add on to it. Okay. Right. Thank you so much. So with this, I will conclude the session. So anybody who wants to add few points? How did you do the general surgery part? How was the general surgery questions, guys? Was it easy or how was it like? All from GIT. I think the GI paper general surgery was also core. Okay, understand. So I think this time the GIT questions are more from Sebastian rather than Bloomgard and Shackelford, I think, right? I'm not sure because I didn't go through it. Okay. So I think Rajaman sir is the right person to deal with general surgery questions because I have been out of touch for many years now. So when it comes to urology, you just keep me in touch. So don't worry about the results. Whatever said and done, you're given your best shot. So rest is not with us. Rest is not with you. You're given your best shot. Just relax for a while, and once the results comes, we will just think about how to reapproach and refocus again. Okay. So thank you so much for your kind listening, and I will share it in a couple of days. Right. Good night. So there are few WhatsApp groups. One is this RRM DocTutorials SS group, that is Telegram group. Or if you're not aware, you can contact Dr. Our Rahul from RRM. He will guide you. Okay. Or you can contact DocTutorials person as well. They will add you into the group. I think most of you will be there in our discussion group. If you're not there, we will just add you in. Don't worry, doctors. Okay. All right. So for those subscribers, there are already complete video lectures on our 12th edition of Campbell. So along with it, with this add up, I'm planning to add this. I'm going to cover the EAU 2023 guidelines as well, because every time there are 3-4 questions coming from the guidelines, I'm going to add that. That will cover the that will be add-on points from the already existing video lectures. I will add on all the latest trials add into it, and also I will touch upon the basic 15-16 chapters where there is more focus on this post-operative complications like your clavity classification, your different energy sources that has already been taken by another faculty. I will try to stress upon those dry areas as well. So that lectures most likely you will get in another couple of months. Okay, right. Thank you.